Further proceedings under the quorum call be dispensed with.
Without objection.
Madam President, I ask unanimous consent that I be allowed to proceed as if in morning business.
Without objection.
Thank you, Madam President. We're in a time when we're talking about money. We're talking about debt, we're talking about taxes, we're talking about stimulus, and we're talking about health care. I wanted to put this whole situation with respect to money into some perspective. And so, having been a businessman, I did my best to try to draw up a balance sheet for the United States. Now, this is a very simplified balance sheet. It is in summary numbers only. But by going to the Federal Reserve Board and the Social Security and Medicare trustees and the Census Bureau, I have come up with the following balance sheet for citizens of the United States. And we start out with assets and liabilities. These are personal assets and personal liabilities. It's amazing to me that the number of household assets on a per-person basis is this high. But it is. If you take all of the personal assets in the United States, lump them together, and then divide them by the number of people in the United States, you get personal assets of $218,000 per person and personal liabilities or household debt of only $45,000 per person. So the balance sheet looks pretty good. However, we have, as citizens of this country, debt beyond our personal debt. So when we add the national debt and each individual's share of it to the balance sheet, that puts an extra $37,982 on, so that the amount of debt goes up when you add each individual's share of the national debt. All right? The national debt is not the only debt that we have. Let's add state and local government debt on a per-person basis, and it goes up another $7,500. But that's not the only debt we have. We have obligations, each one of us, with respect to Social Security. There is a Social Security liability, and the present value of that Social Security liability is another $17,251 per person. All right. It still looks like a pretty good balance sheet. With the assets at $218,000, this is about half. But there are two other liabilities that we have to put on the balance sheet. The first one is the present value of Medicare hospital insurance. Over the next 75 years, the present value of that unfunded liability is $43,616 per person, almost as much as the total amount of debt that each one of us has as an individual. And now the balance sheet is looking a little scary. But we have one more item that we have to put on the balance sheet, and that is the present value of Medicare supplemental medical insurance. And that's another $79,095 per person, so that you add it all up, and this is the balance sheet that we are facing today. $218,000 in assets, $231,000 in liabilities. If this were a corporation with this balance sheet, we would say the corporation is underwater. Now, as we begin to break this down, we realize that the Medicare liability is more than everything else put together. The Medicare liability is more than our personal debts, our share of the national debt, our share of state and local debts, and our share of Social Security. The Medicare liability is more than all of that put together. Is it any wonder then, Madam President, that the number one thing we should be talking about when we're talking about health care is how to get the health care cost under control? To use the terms that the budgeteers use, how to turn the cost curve downward. on health care. We can talk about earmarks. We can talk about spending on appropriations bills. We can talk about holding down discretional spending on other issues. And all of those things are worth talking about, but they are dwarfed by the challenge of turning down the cost curve on health care. I've said this before, but it still works. One of the statements that has gotten into American folklore is the statement attributed to Willie Sutton. Willie Sutton was a bank robber. Not very many people knew much about his robbing banks, but he kept doing it. He would get arrested, he would get on parole, or he would leave prison, and he would rob another bank. And finally, someone said to him, "Willie, why do you keep robbing banks?" And he said, "Because that's where the money is." If we're going to talk about the balance sheet that every American faces in debt and debt obligations, we have to talk about health care because that's where the money is. More for health care liabilities than everything else put together. All right, let's discuss this question of turning the cost curve down. How good a job have we done as a government in making projections as to the cost of health care? On the second chart, let's look at the years and at the projections. In 1965, when Medicare was first proposed, we made a cost projection, we, the government, made a cost projection as to how much it would cost us, and that is represented by that red bar there on that chart. Then the actual numbers came in, and they are represented by the green bar on the chart. Let's look at 1965 Medicare hospital insurance. That's a separate program. The cost projection is there in the red bar, the actual figures that came in on the green bar. 1987, we added Medicaid, and the Congress was told, and the Congress told the people, Medicaid won't cost much at all. You see, it's hard to find even on the chart. The actual cost was 17 times the projection that was made. In 1988, we added Medicare for home care. It was going to cost a little more. Once again, the gap between the red bar and the green bar, it's always cost more. We did a little better with S-CHIP, but S-CHIP is still a relatively new program, 1997. So the disparity between the projection and the reality is relatively small, but once again, the reality has been greater than the projection. There is one exception, and that is Medicare Part D, and that is the final pair there. The red bar shows what was projected that Medicare Part D would cost, and the green bar shows almost magically this one cost less than the projection. Why? I want to quote from an editorial in the Wall Street Journal where they quote from White House Budget Director Peter Orszag. Peter Orszag was the head of the Congressional Budget Office at the time that cost projection was made. This is what the Journal has to say. Quote, but as White House Budget Director Peter Orszag told Congress when he ran the Congressional Budget Office, the primary cause of these cost savings is that, quoting from Orszag, the pricing is coming in better than anticipated, and that is likely a reflection of the competition that's occurring in the private market. Close quote from Peter Orszag and from the Journal. I will repeat that, however. That is a reflection of the competition that's occurring in the private market. Now, the Journal goes on to point something that I recall because I was here during that debate. I was part of that debate. And the Journal says liberal Democrats fought that private competition. preferring government drug price controls, just as they are trying to prevent private health plans from competing across state borders now. The lesson here is that spending on nearly all federal programs grows relentlessly once they are established. This history won't stop Democrats bent on ramming their entitlement into law, but every member who votes for it is guaranteeing larger deficits and higher taxes far into the future. Count on it. Close quote. The history of cost containment with respect to health care is not a pleasant one. The history of predicting what health care will cost is not a pleasant one. The only example we have where costs have come in lower than projected has been in that circumstance where competition in the private sector has been protected. That has been the core of the bill that Senator Ron Wyden and I have introduced as the Healthy Americans Act. Private competition absent a government plan. We look at the history and say, that will turn the cost curve down. That will begin to save money. CBO examined our bill. Peter Orszag was the head of CBO when they looked at our bill and said, it is revenue neutral, that's a good start, and then likely to save money in the future. They didn't put a number on it, but the Lewin Group has put a number on it and said that the Healthy Americans Act, co-sponsored by Senator Wyden and myself, would save $1.3 trillion over the next 10 years. I don't know whether that number is right or wrong. I do know it's wrong. I don't know how far wrong it is. But the point is, it demonstrates turning the cost curve down rather than turning the cost curve up. And that is what we have to do, as our balance sheet reminds us so dramatically. So let me talk briefly about the idea of a government-run plan, a private option, a public option, whatever it is we want to call it, as the way to turn the cost curve down. Once again, the history of government-run plans is not encouraging about turning the cost curve down as we look at Medicare and how little it was supposed to cost and how dramatically much it has cost. Let me quote from Robert Samuelson in his column that appeared in the Washington Post just recently. He says, Medicare has a low marketing cost because it's a monopoly, but a non-monopoly public plan would have to sell itself and would incur higher marketing costs. Private insurance profits, included in administrative costs, also explain some of its Medicare cost advantages. But profits represent only 3% of the insurance industry's revenue. Moreover, accounting comparisons are misleading when they don't include the Medicare government-supplied investment capital. So we're trying to mix apples with oranges when we say, oh, look at the low administrative costs with Medicare, look at the high administrative costs with private insurance. Medicare can do it cheaper. Every projection about Medicare doing it cheaper has demonstrated not to work out. Samuelson has this to say, quote, the promise of the public plan is a mirage. Its political brilliance is to use free market rhetoric, more choice and competition, to expand government power. But why would a plan tied to Medicare control health spending when Medicare hasn't? A favored public plan would probably doom today's private insurance. I think that's true. That's one of the reasons I am opposed to that kind of thing. Samuelson goes on to make this final comment. He says, many would say, whoopee, get rid of the sinister insurers. Bring on a single-payer system. But if that's the agenda, why not debate it directly? It's not insurers that caused high health costs. They're simply the middlemen. It's the fragmented delivery system and open-ended reimbursements. Would strict regulation of doctors, hospitals, and patients under a single payer provide control? Or would genuine competition among health care plans over price and quality work better? That's the debate we need. Close quote. I agree, Madam President. That's the debate we need. That's the debate that focuses on how do you get this cost curve under control? How do you start to turn it down? How do you get the kinds of score that Senator Wyden and I have gotten from CBO that says our plan is revenue neutral and that others say will save $1.3 trillion over the next 10 years compared to the cost history of government-run plans that say they're only going to cost this much and end up costing that much and driving us to this kind of present value liability, twice as much as everything else put together. That is a staggering thing to contemplate. But that's what brings us back to what I said at the beginning. The core of this debate should be focused on how we turn the cost curve down. I have one more comment to make with respect to that. As I have worked with Senator Wyden over the last 3.5 years to try to understand this issue and try to come up with solutions to it that make marketplace sense rather than political sense, I have come to discover a great truth that we don't seem to be discussing here in this debate at all. And that is this: the greatest cost control factor in health care is quality. The best health care is the cheapest. And we have built into the system now incentives that drive us away from the best care. And most of the perverse incentives that drive us away from the best care and to the highest cost are in Medicare. They are in the Medicare system that has gone 10 times, 20 times above its original cost, and they're still there. We should be, and the care that they produce is less than the maximum care that people can get when they go to the places that give us the best health care. It's parochial for me to repeat this, but I'm happy to do it on every occasion. Dartmouth has done a study as to where the best care is available throughout the United States, and they've said it's best available in 3 cities: Seattle, Washington, Rochester, Minnesota, and Salt Lake City, Utah. And then they say, if every American got his or her health care in Salt Lake City, Utah, it would be the best in the United States and 1/3 cheaper than the national average. Because of a variety of reasons, they practice the best health care and they have focused on outcomes rather than the kinds of perverse incentives that are built into government-run programs. We've got a lot to do and a long time to go before this health care debate is finished. But I hope we recognize that hanging over it, regardless of everything else we say with respect to health care, is the fiscal reality that our current present value obligations for health care dwarf every other debt we have in the United States: personal household debt, the national debt, state and local debt, and Social Security debt, all put together, do not add up to the amount of health care debt that we are facing. The challenge of turning the cost curve on health care down is the #1 issue we should be addressing as we're talking about this. And the irony of it is, if we are successful based on what we know, we can get the cost curve down and produce a better health care outcome and result. I yield the floor.
Madam President.
The senator from Ohio.
I ask unanimous consent to address the Senate for up to 10 minutes as if in morning.